Good morning, everyone, and thank you for joining us for a discussion this morning about employer-sponsored health insurance. I'm Bill Hoagland, I'm Senior Vice President here at the Bipartisan Policy Center, and I have the pleasure of working with our economic and our health team on addressing those policies that impact so many of our lives of so many of our Americans out there. And given that there are well over, 156 million Americans, about 70% of the population receive their health insurance through the employer, I think it's only appropriate that we would focus on employer-provided health insurance as a major project here at BPC. We launched this, our review of employer-sponsored insurance, ESI, back in last winter. Thanks with the help and support of the Robert Wood Johnson Foundation. And this is the second of public events that we were having on this particular subject. That first event back in January, I think highlighted what so many of us know, that employer-sponsored insurance really is a backbone of our health care system. And it is, according that first event we had, did emphasize, even from employers and employees, the value even employees place in getting health insurance through their employer. But there also was a broad agreement that there were underpinning challenges to our healthcare employer-sponsored system through the increasing cost and generally, but more specifically, high and rising prices. And those increases in prices have been seen in premiums and deductibles that have increased over the last decade or so, and particularly impacting lower and middle income families and reflecting in some ways a lowering of their individual wage growth. So today we want to target our discussion on what specifically employers, employees, policymakers can do to address prices at the hospital level, over the counter at the drugstore, at the doctor's office, or wherever we interact with the healthcare system. And our goal here at BPC is to advance in our final report that we hope to issue later this summer, some very specific bipartisan policies options, not to weaken the ESI system, but in fact to strengthen it and increase its effectiveness in providing healthcare to all those who receive it through their employer. So today we're joined by 4 excellent experts who will share their perspectives on empowering employers with payment, pricing, and market tools to strengthen ESI set. With us this morning, first of all, is Eric Socker, and she's the Vice President of the Healthcare at the Arnold Foundation, Arnold Ventures. Susan DeBacco, Executive Director of Catalyst for Payment Reform. Ovik Roy, one of BPC's policy advisors and President of the Foundation for Research on Equal Opportunity. And finally, but not least, Limor Daphne, an economist with the Harvard Business School. I'd like each one of them to make any kind of quick opening remarks they want to have, and we'll go from there. So let's start, Erica.
Sure. Thank you, Bill. So good morning, everyone. As Bill said, I work at Arnold Ventures. We're a philanthropy that focuses on solving domestic policy problems, including healthcare. And our healthcare work really centers around improving affordability and trying to get a better return on investment for what we're spending on healthcare. As we all know, we're spending a lot, we're not getting good value in many cases, and we're not getting better health outcomes. So when you look at the employer market, as Bill said in the opening remarks, our healthcare cost problem in the employer market is really a pricing problem in many cases. And so this is a big focus of our work, and we're doing work to support both evidence development around the problem, around potential policy solutions, and then also supporting work to help policymakers and others actually implement solutions. And this ranges from topics like surprise billing to market competition issues, to some work that is focused on more directly reining in prices where there are major pricing problems.
Thank you, Erica. Suzanne.
Hi, I'm Suzanne Banco. I'm the Executive Director of Catalyst for Payment Reform. And if you're not familiar with our organization, we've been around about 12 years. We're a 501c3, so a nonprofit educational organization that provides thought leadership to and coordination among employers and other big healthcare purchasers, including public purchasers, who want to get better value for their healthcare spending. And as our name suggests, payment reform is part of what we focus on, changing how we pay doctors and hospitals. But if you want to get better value, you have to think about many other fundamentals. What is the benefit design being used? What providers are included in the network? How much transparency is there around prices and quality? What is the marketplace dynamic? Is there any leverage on the part of the employer, or is it all with the provider, depending on where you are? And taking all that into consideration, what's the path forward for making sure that employers and those for whom they buy healthcare can have affordable, decent quality, accessible care? And the biggest issue we think about every day is prices. So I'm really glad to be here today.
Thank you, Suzanne. Ovik.
Hi, first of all, I just want to thank the Bipartisan Policy Center for organizing this forum, really important topic. I think the place to start is to add on to what Erica said. The price of healthcare in the employer setting is high and rising, whereas Medicare and Medicaid prices have been relatively constant relative to inflation over the last 20, 30 years. So why is that? Why is it that the prices employers pay for healthcare has continued to rise? And one big element of that is that employers don't have enough visibility, at least most employers don't have enough visibility into the distribution of prices in the marketplace for the services they need. And this is something that we're now starting to see important reforms, developments, changes, opportunities that employers can use to finally begin to take their workers and drive their business to the providers who are delivering the best value and the highest quality care at the best price. But there are plenty of places in this country where even if there were more visibility, more transparency into healthcare prices, that wouldn't be enough because of the rise of regional monopolies, particularly among hospital systems, that give employers in a particular locality little choice as to where they get their care. So I hope that today we'll get to spend some time on both of those topics.
I think we will. I think definitely we'll get into that. Thank you, Ovik. And finally, Limar, Harvard.
Glad to be here with you today. Thanks for the opportunity to be on this terrific panel. I am a health economist. I also am a professor of strategy at Harvard Business School and Harvard Kennedy School. I've been doing research on competition in the healthcare markets for more years than I care to admit. And for a long time was focused on consolidation among healthcare providers and the contribution of that consolidation to high and rising prices. I'm still greatly interested in that topic, but some of my more recent research is on drug pricing, which, as others have stated, is high and increasing and an area of great interest for employers and for employees. And in particular, something that I hope we'll get a chance to talk about today is the role of pharmaceutical companies in sponsoring assistance to offset patient cost sharing, which research that I've done has shown leads to price increases of these drugs, therefore exacerbating the spending problem. So any of the proposals out there about capping out-of-pocket spending, I think ought to be married with something related to these assistance programs that help to push up prices. So that's something that I'm looking forward to discussing, and all of the other topics are clearly important. Thanks.
Thank you, Limar. Appreciate it. We're going to get into a lot of the questions that all of you have already keyed up here. But before jumping into those questions, some of them prepared some of my questions, along with a number of questions that the staff here at BPC would like to get clarification on. I want to remind those of all of you who are tuning in that you can submit questions via the Twitter through hashtag BPC Live. or use that chat device on the YouTube going forward. Hopefully, we'll have an opportunity and time to answer or address some of your questions, but if not, know that we will review all for the final report we're putting together. So with that, let me jump right into it, and I'll ask my first question of Erica. But as with all our discussion today, I welcome each and every one of you to respond if you feel necessary. Erica, a recent January CBO report, and all cards on the table, I'm an alumni of CBO, so I may be biased here, but found that over a 5-year period, prices paid to providers by commercial insurers increased at an annual rate double those of Medicare fee-for-service, something that Ovik mentioned in his opening comments, and that prices paid by commercial insurers for similar services varied widely across. CBO goes on and asserts that commercial insurers are often not incentivized to negotiate lower prices because they can pass the provider's price increases on to employers. From your perspective, Erica, what are some of the existing authorities or tactics, or any, that the federal government could utilize to incentivize commercial insurers to negotiate lower prices for their beneficiaries? Any thoughts?
Yeah, so thank you, Bill. I mean, one thing I would say is I think transparency, as others have said, is really foundational here, and that we're making some progress towards having greater transparency around healthcare prices, especially over the past couple of years, and making sure that both purchasers and plans have information to the rates that are being negotiated for hospital services and physician services. And I think this is something that could help insurers and employers be able to negotiate better rates with hospitals in particular. But I think, as others have said, like, there really still is this market power issue. And so transparency is necessary, but I don't think it's anywhere near sufficient for getting at this problem. And that applies to market power for the employers that might be trying to negotiate lower rates, but also the insurers that are trying to negotiate lower rates on their behalf don't always have a lot of market leverage relative to the big dominant health systems in certain markets. And so I think we could be thinking about kind of improving incentives to help insurers negotiate better prices. And I think there are things we could think about doing there, like around the medical loss ratio, for example. But I think really this comes down to the problem of how much negotiating leverage both plans and employers have. And I think there we need to be considering solutions that push beyond transparency. Trying to limit further consolidation, I think, is one thing. The cat is really already out of the bag in a lot of markets, though. We have highly concentrated markets in many places. And so I think we need to be also considering ways we can more directly kind of target market failures in particular areas. I think this price billing law was one example of that, but other places where we should be considering more direct limits on prices, where we're in a situation where we can't really restore competition. The market is not functioning. And so what do we do in those cases where the high prices are really reflective of market power dynamics, not higher quality?
We'll get into this in just a second here, but it's just to get it up, clear the tables right up front, and then maybe this is a yes, no answer from each one of you. There always is this issue, and I'm being an old budgeteer, always worry about these things, that the argument is made that because of lower Medicare reimbursement rates lower than at the level that they are, that there's a cost shifting, and that's why the private commercial rates are higher. I think I know what each one of you are going to say, but is that true? Suzanne, yes, no?
I'm a big believer in price discrimination, that hospitals, health systems will charge whatever they can to each payer. And it's not so much that they have a great spreadsheet in front of them that says, "Ooh, I'm falling short here, so I need to charge more over there." In fact, most hospitals don't actually do proper cost accounting. They just know what the top line is and how they need to make up for it. And in markets where there is a lot of competition, we see hospitals doing much better on those public rates than in hospitals where than in markets where there's very little competition. And so hospitals don't have to work hard to cut their costs out of their system.
So the answer is there's no cost shifting out there. Is that it? Okay.
It's price discrimination.
Okay. Dr. Daphne, given your expertise.
The answer is no.
Okay. And Ovik?
No, and if I can go beyond one word, I'd just say there's plenty of empirical evidence to indicate that the answer is no. We can get into that if you want.
So, and Erica? Yes,
That's
no.
a no for me as well. I think, as Ovek said, I don't think there's empirical evidence really to support that argument.
Okay, so I can concerned about the federal budget and expenditures. If I want to argue that I should reduce reimbursement rates for Medicare out there, I should not be worried that that's going to shift in terms of the private sector, according to our experts here today. Okay, not that I'm going to have any success with that.
I might put an asterisk on that, Bill. I don't think you necessarily. You can make an argument, and I would make the argument. We would make the argument at Free Out, my think tank, that you don't necessarily want to use a completely blunt instrument in terms of just having uniform one-size-fits-all pricing as a solution, but there is a role for price ceilings, as we've seen in Medicare Advantage. Medicare Advantage takes advantage of Medicare's fee-for-service price ceiling as a way for insurers and providers to negotiate very effectively and really cut the head off of the monopoly price exploitation. So, for example, as a private insurer in the case of Medicare Advantage, you're not limited to the fee-for-service rate, but if a provider really wants to get aggressive with you, you can say, well, I'll walk away, and then you have to accept the Medicare rate. And that balances the playing field from a negotiation standpoint in a way that the traditional system does not. But it also creates some flexibility around pricing that allows payers to say, hey, this particular surgeon or this particular primary care physician or this particular provider, they're doing a great job. I want to pay them more and steer more people their way and make sure that we have pride of place in their system, in their panel, because they do the best work. So that has been a success story, I feel.
Let's thank you, Ovik. And this kind of sets up a question. It's already been raised a number of times here. My recollection is Department of Justice and the Federal Trade Commission, I believe it was last summer, withdrew some regulations as guidelines for standards for merger consolidation. I think it was primarily as it related to vertical integration as opposed to horizontal. But anyway, and then here in January, and I'm not a lawyer, certainly not a antitrust lawyer, have no experience in this area, but years with this expertise on the line. I think in January, just this January, DOJ and FTC launched a public inquiry aimed to modernize merger guidelines. If BPC were to recommend to the Department of Justice and FTC changes to standards for permissible mergers be considered, particularly as it relates to the healthcare industry, could you give BPC staff here any guidance on what you suggest? And I know, Limar, you have testified last year on this subject matter. What should we do?
Right. So you're referencing the request for input from DOJ and FTC. Comments are due, I think, in a little under a week. So I would suggest BPC get on it. But the revisions are meant to address ideally both horizontal, that is same product market, same geographic area combinations, as well as combinations up and down the value chain, and then anything else in between. So when it comes to healthcare transactions, we're seeing all of that. The guidelines and antitrust enforcement put guardrails on the activity that occurs. They are meant to illustrate how the agencies enforce our antitrust laws. And so question is, what is not really being addressed and could be addressed through antitrust enforcement? I would highlight a couple of things. There are a lot of problems in healthcare, including I'd love to comment on what Ovik mentioned about price caps and so forth. But there are only a certain set of problems that can, I think, appropriately be addressed through antitrust enforcers. And acquisitions and mergers are one of them. One issue we've had in a lot of healthcare settings are what are called serial acquisitions or roll-up strategies, if they're often done by private entities. It is in the past, the authorities have not challenged these transactions because their interpretation of the antitrust statutes are that any deal has to be a significant change, substantially lessen competition, tend to create a monopoly, which means that if you slowly create your monopoly, it can be difficult in court to demonstrate that that is anti-competitive per a narrow interpretation of the statute. So I think a statement with regard to look what's happened on the ground, this is not an interpretation that is consistent with promoting competition in our healthcare economy would be useful. So serial acquisitions is one. Another that we've seen in healthcare are what I call cross-market competitions. So if a dominant system in where I'm from in Houston merges with a dominant system in Dallas, Ovik, I read that you had some time in San Antonio. I don't know where you are right now.
Austin.
Where's that? You're in Austin?
Mm-hmm.
Okay, throw that area in there too, because patients don't typically travel across these cities for their healthcare. That would not be a standard transaction to challenge, but research that I've done shows that these cross-market transactions, particularly within the same state where the hospitals are negotiating with the same set of insurers, do tend to enable price increases. So there's a set of transactions that need to be looked at a little differently than they previously had. So I'll stop there, but if your staff wants to.
Thank you, Lamar. We're going to come back. We're going to come back to this. I think is a theme that's running through this discussion already. But Suzanne, shifting to enhancing the employer market power in the face of this issues of consolidation. Employers, there are employers, as I understand, and you're the expert here, have been deploying innovative approaches to drive down healthcare costs. Problem, I think, though, is often scale. Even large employers do not have the volume of covered lives to make a meaningful impact. The Commonwealth Fund Catalyst, I believe, made a study here recently that indicate few parameters under which such coalitions can be successful. Give us some, are these purchasing coalitions and multi-payer models, are they having an impact? Could they have an impact? How can we encourage them? What's your thoughts?
Well, yeah, what we found is exactly what you're describing, which is there are very few geographic markets in this country where any one employer can have enough market heft to be able to drive down prices. And there are a few places where that can happen, but very few. So we wanted to investigate why there are so few examples of employers coming together to use their collective leverage to purchase healthcare and drive down prices. And it turns out there's all kinds of stumbling blocks that get in the way. And that's why we have just a few examples. I'll point to the Alliance in Madison, Wisconsin, or the Peak Health Alliance in Colorado as some successes. It's very hard to get different employers in the room and have them agree to what it is that they want when they purchase healthcare and what it is that they want for their employees. So that is one of the stumbling blocks. There are antitrust issues that they have to be careful with. There is an asymmetry of information that is getting better because of some of the new transparency laws, but it's been difficult for employers to really understand exactly what they should be paying, what they could be demanding. So we see very few examples of this succeeding. Sometimes where the soil is just right, where there is enough competition among providers, and there are some employers who have enough common goals that they can put aside their differences, we do see some great examples of success. Individual employers where they've succeeded has been through direct relationships with providers, where they have said, we want a certain level of quality, we want a certain level of access and patient experience. And in exchange, we'll create an option at open enrollment that our members can select and potentially drive more business your way. So those are some of the examples where we've seen success.
Thank you. Thank you very much. Erica, we're going to shift here again and then come back in a short time back to the competition issue. But when we talk about prices, obviously hospitals being a major issue here, the National Academy of State Health Policy, with your support from the Arnold Ventures, developed something called a hospital cost tool that uses Medicare cost report data submitted annually to the federal government to calculate several cost variables. I was struck by one of your users, Mary Bartlett, who I guess was a former administrator of Montana State Employees, said that she was able to take this approach of this cost model that you have. And she said, okay, here's my data. I've looked at your Medicare cost report. I can see that you could break even at this level, and I'm paying at this level. And I had very effective use of this tool. Can you share with us this powerful tool, apparently, that could be used out here, and how it works and how people can utilize it, I guess?
Sure. I mean, the hospital cost tool is pretty neat, really. It starts to shed light on hospital finances in a way that we haven't necessarily seen before. And really at the specific hospital level, we can look at their costs, at their revenue, how the costs compare to the prices that they're charging. And we can also look at things like their profits. And so it starts to really kind of pull back the curtain on hospital finances. And I think can be really useful for employers and for policymakers around kind of education about what is going on with hospital pricing and with their cost structures, and also hopefully in policy design, as you mentioned. So one concept that comes out of here, which is part of what Marilyn is referring to, is this concept of the commercial break-even point, which means let's take hospital costs as given, let's incorporate the revenue that they're already getting from public payers. And then what do commercial prices need to be to make sure that hospitals can break even on their costs? And that is assuming that the hospital costs are fixed and that there is no opportunity for them to lower their costs at all. And so I would say that's a pretty generous definition of hospitals' cost structure, and there probably is room for those costs to come down in some places. But what we see is that in a lot of cases, the prices that are being charged by hospitals exceed what this break-even point is. And so this was helpful to Maryland and Montana, this type of data for really negotiating lower rates and implementing price caps for the state employee health plan there, tied to a percentage of Medicare. We've also seen NASHB has been working on versions of this tool for a little bit now. And so we have seen other states use this as well. Colorado, when they were thinking through their public option proposal, also used some of this data to try to think about like what rate was appropriate there. And so I think this has a lot of uses and is a really rich new data source that's out there.
Thank you. Thank you, Eric. I'm going to jump back to Ovik, and then we'll come to Lamora on the pharmaceutical issue. But I want to go back to the competition issue. And Ovik has participated in a previous PBC report. You were instrumental in having our task force recommend some form of a use of the Herfindahl-Hirschman index score to negotiate lower prices. Is this a tool? We haven't followed up, Ovik. I don't know if anybody has picked up on this, but is this? I like the idea. Where can we go with this proposal?
Before I do that, I want to amplify something that Suzanne and Erica both mentioned, which is that if you talk privately to hospital executives, they'll tell you that the way they manage their prices is basically to meet a cost number, right? Like they're going to spend this much, so they're going to kind of massage their prices to equal this much plus 2%. That's kind of what you see a lot of people do. And there's no cost discipline if you're a monopoly, right? So what they'll do is, they don't have any incentive to say no when someone demands higher prices, if they have one neurosurgeon, the neurosurgeon can charge more, and they just say, okay, fine, because to them, they could just pass on those higher prices or higher costs in the form of higher prices, right? So what we see actually is that in competitive environments, costs are somewhat lower, slightly lower than they are in monopoly environments, because just like in the rest of the economy, when you have a competitive economic sector, businesses have to keep their costs down because that's the only way they can keep their prices competitive. And so they're very disciplined about costs because it's the only way they can keep their prices down, right? That is less true in healthcare for the reasons we've been talking about. And that's part of why costs go up. So when you hear hospitals say, well, we've got to do X because our costs are so high, what often is missing from that conversation is a rigorous examination of why their costs are so high, because there's very little pressure for them to keep their costs down. So that brings us to your question, Bill, which is we had this idea that I've been working on various gigs previously at the Manhattan Institute and then at the Foundation for Research on Equal Opportunity that we talked about also extensively at BPC, which is what if we could use the Herfindahl-Hirschman Index, this measure of market concentration that's typically used by the FTC and the DOJ, as a trigger for a Medicare Advantage style price ceiling. So the idea would be, it would have two functions. So basically, the standard thing you hear people say is, well, let's increase enforcement by the FTC and the DOJ to break up new mergers that happen. And that's important, that's useful. But the problem is the hospital sector is already so heavily consolidated that if you use enforcement to break up the mergers of the future, you haven't really done anything to break up the mergers of the past. And the FTC and DOJ have been historically very reluctant to break up past mergers because in the hospital space, because they're just worried about the instability that it may cause to the provision of important healthcare services. So they've just wanted to stay away from that. And so what's beautiful or attractive, I should say, about this HHI-based tool is it's not a one-size-fits-all system, going back to something we were talking about before. What it says is if your hospital system exceeds or a proposed merger exceeds a certain threshold of market concentration as measured by the Herfindahl-Hirschman Index, or in the legislation that we helped build called the Hospital Competition Act that's been introduced in the House and the Senate, the threshold basically applies to urban centers, not rural, because rural you have more natural market concentration, but in urban centers, if you overcome that threshold, then Medicare Advantage prices apply in that setting, meaning kind of like how MA works today, the insurers would be able to say, this is our MA rate, we can pay that. You can't charge us 3x the Medicare fee-for-service rate. You have to accept our MA rate in this geography. And that has turned, that's an idea that not only prevents price exploitation from regional monopolies, but it actually gives those regional monopolies an incentive to break up without FTC action. So right now, if the FTC wants to bring an enforcement action, it takes 3+ years to wind its way through the courts. Who knows what the outcome is going to be? As Lee Moore has studied extensively and documented extensively, a lot of the outcomes from these cases, at least historically, have been the judges have been indifferent to the consolidation. That's starting to change, but it's certainly in the 1990s and 2000s, this was a big problem. So what you can do is instead of relying on the FTC and the DOJ to appeal to judges to break up these mergers, you create a powerful economic incentive for the monopolistic hospital systems to break up on their own. Because if they disaggregate into smaller units, such that the market concentration in that region gets below the HHI threshold, in our case, it's I think 4,000 or 5,000, then you create more competition organically in a way that the businesses can voluntarily, in a sense, decide, do we think we add more value from economies of scale by being very concentrated? They always say in their mergers, well, we're merging because this is going to be great for patients. Well, if it is, then the prices shouldn't have to double. The prices should actually go down because there's economies of scale, right? So if they can achieve that, then great. But what this model of using HHI as a threshold for MA-based price ceilings does is it allows you to say, well, if that's not the case, if you're just using the merger to raise prices on patients, which is typically what happens, then we're going to basically cut that off as an option. And that then steers the entire economic incentives of the sector to disaggregate, to create more competition, to recognize that mergers are not going to be the way to make more money. The way to make more money is to provide more value to patients. And that is so that's the attraction of the model. It's optional. Like if you're a system, you don't have to consolidate. You don't have to stay in monopoly if you don't want to. And as I mentioned, it is now a bill. So there's several bills in both the House and the Senate that have been introduced: the Hospital Competition Act and the Fair Care Act that use this model to reduce healthcare costs. And we estimate that the savings could be significant.
Good. I have a feeling that Dr. Daphne might want to respond, but also while you're thinking about responding to what Ovik has outlined here, I also want to start to throw into this discussion the role of private equity investments. And but first of all, Lamar, go ahead and
Okay. Yeah.
give your thoughts, but can we also start to think about what does private equity promote consolidation also?
Thank you for throwing that out there. Thank you, Ovik, for raising this idea of now becoming increasingly bipartisan of a price ceiling, which has the advantage of, to the extent that markets are not yet consolidated, taking the wind out of the sails of would-be merging parties who would otherwise end up, potentially they're motivated by, but even if that weren't, the board's motivation would end up, due to the lack of competition, raising price. So I too have co-authored a proposal with Mike Chernew of the Harvard Medical School on a price ceiling. We don't advocate linking it to Medicare, which politicizes Medicare even further. So we recommend linking the ceilings to commercial prices, but the idea in principle is the same. The one slight area of disagreement I want to highlight is that it's appealing to focus on market concentration, but the truth is that the current metrics are so crude that we did this analysis, published it in Health Affairs. More than half of the hospitals that are very, very high priced are located in markets that are not, by this definition, highly concentrated. So we would say if you want to go after really high prices, because that is so likely at those levels to illustrate exercise of market power, or what I would call endogenous costs that rise because you have the market power, then go after the high prices, set the ceiling independently of exactly what the HHI is, and then you could have broader impact. So that's the main comments that I wanted to make on the price ceiling. Private equity. So this is an area that is of growing concern in healthcare circles. We see a lot of what is known in the sector as dry powder, cash sitting around in these funds looking for homes. What
did you call it? Dry power?
Dry powder. Yep.
Okay. All right.
And looking for things to buy and looking for fairly short-term returns, which creates an incentive that is somewhat different even from the publicly traded for-profits who might have longer-term interests in the enterprise. And in terms of the motives for consolidation in that sector, if you aggregate mom and pops into something more sizable, the valuation increases. I have yet to hear a great explanation for what the limiting point is for that. But nevertheless, it is an area that increasingly states are growing concerned about. So I see some nods and we'll stop there.
As a free marketeer, and I appreciate all your responses to this, how do you control that though? How do you stop?
This is not an area that I have developed a well thought out policy, but one could imagine requiring certain sizes of stakes. Because one of the risks with private equity investments is you own a very small amount. You have a very big incentive to engage in practices that might have a huge payoff. Think surprise billing. and then have serious ramifications on our healthcare setting. So potentially require a larger stake, require a longer length of period of time in which you have to hold it. In the state of California has proposed, there's legislation that is proposing more oversight and having the entities demonstrate and measure what they're doing following transactions and requiring even approval. I'm not advocating for that. I'm just giving you ideas on what one could do.
Thank you. We kind of get a picture here of negative aspects of consolidation, but we do a lot of work here, have done a lot of work in the rural hospital areas, small practices. I always hear that they would not survive if there wasn't consolidation. Are there benefits to consolidation, I guess, particularly as it relates to rural America?
So one comment I would have to make is that if that is almost evidence of use of market power. So we have consolidation and we're going to use some of the gains to prop up rural hospitals because that's a value that we have. Now, we didn't elect the health systems to office to decide how to dispense funds, plus funds that are realized through market power create all kinds of inefficiencies. So do government funds. So to me, the evidence that being acquired by a big rich system and then being able to keep doors open, that's not evidence to me that they have operationally improved things about rural hospitals. Doesn't mean, I want to be clear, I don't believe all consolidation is bad. It's just that on average, the consolidation we've seen has not helped consumers. So any particular consolidation needs to be studied on its own merits.
I want to remind our viewers, if you have any questions you'd like to submit to these experts here, please enter it through the BPC #BPC chat live, or as I said, the chat on YouTube. Suzanne, and maybe all of you, because we've talked about transparency again, not having the skills that all of you have. I've always, as a pseudo economist, I guess I would say, thought that information was the best thing going for people deciding. Obviously, healthcare is a little bit different in this regard, but price transparency is another tool. And that Consolidated Appropriation Act that was enacted last December, plus, quite frankly, let's be honest, the Trump administration's regulations as it relates to hospital transparency, all that is out there. And yet I don't get the sense, in fact, at least the statistics would indicate that less than 20% of surveyed hospitals are even are allowing individuals to view discounted cash prices. What's the problem here? What's going on? Susan and Erica, maybe respond.
I'll just start and say that, my organization's been pushing for more transparency for 12 years, and we have come a long way, but there are so many ways to game the system and to make it not that useful. And one of the ways is just not to comply with reporting, which is what you're referring to, Bill. The other is that if we don't have standard definitions of how we define a given service or episode of care, it can be very easy to be fully transparent, but to have the information that's out there not be apples to apples comparable on the part of a consumer or a purchaser. And the last thing I would say is that the foundation has to be transparency, but it's not sufficient. If a health system has market power, they can say, yep, you're right, my prices are higher. What are you going to do about it? So transparency is not the solution in and of itself, but I'll turn it to Erica. I'm sure you have more to add.
Yeah, thanks, Suzanne. So just to build off what Suzanne was saying, I agree. I think transparency is really important and foundational. We've been very supportive of the transparency efforts as well. But I think, as you say, Bill, we've seen very low compliance so far. I think part of that is that the penalty was initially very low for non-compliance. It was $300 a day, which for most hospitals is really nothing in the grand scheme of their revenue. And so the Biden administration has strengthened the penalty. I do wonder, like that took effect at the beginning of this year. So I do wonder whether we'll see greater compliance going forward. But I think even with that, like some of what we know about the limitations of transparency and why it's like important but not really sufficient is that we have seen in states where they've had consumer facing transparency tools, there's pretty low use of those tools by consumers. They don't always save money when they use them. If we think about shoppable services, they're really a relatively small share of total spending and out of pocket spending in the employer sponsored market. And so I think there's a lot of work to do to kind of build on transparency, make that information more usable, make it more apples to apples, as Suzanne was saying. And if I could just throw out one additional thought on transparency that goes back to the private equity discussion, I think we also need to be thinking about transparency in other places beyond just price transparency. So private equity, one thing that has been very hard to get data on is kind of private equity ownership of physician practices, and being able to track that over time is really difficult and is like a fundamental kind of gap in our understanding. I think as Lee Moore said, like the evidence around private equity has really been increasing pretty rapidly over the past couple years. I think what we know suggests it's stronger in some areas than in others, but I would say what we know so far suggests there's some reasons to be concerned about private equity's growing involvement in the healthcare sector. And so, like you had asked about policy solutions, I think we can think about private equity specific policy solutions, and transparency of ownership, I think would be one of those that really is a no-brainer, I think. But I also see private equity as an indicator that there is an underlying payment issue and underlying market failure. That's very much what we saw in surprise billing. And so some of the policy solutions, I think, also should be targeted, not really private equity specific, because there's other actors that are taking advantage of those market failures as well. But we should be thinking about solving the underlying payment issues where those exist too. I think that would help on the private equity front.
Thank you, Erica. Ovik, there's a questions come in for you. If we use MA style prices in places with high HH index, would we also need to ban balance billing by the affected providers? I'm not sure I understand the question. Maybe you do.
Well, let me rewind for just a minute before I get to that. So a couple things I want to mention about the overall concepts. This is something we've been developing for about a decade. It was first introduced as congressional legislation in 2018. And the reason why we focused on consolidated markets is because our whole philosophy is we want the solution to this problem of high prices to be market competition, where hospitals and providers, inpatient facilities in particular, are competing against each other to provide the best value and prices and outcomes to patients. So if you just have a price ceiling that's not targeted in that way, that's sort of a price ceiling that's more global, you don't solve that problem, right? A price ceiling that's global is indifferent to whether hospital systems are consolidated or fragmented. It just says, if you are consolidated, you can't charge more, right? Our goal is to say, we want to have a system in which there's free pricing, not controlled pricing, but where there's market competition and a fragmented provider market, so that you can have that competition where payers and providers can negotiate with each other and play off of one another to get the best outcome for patients. So you can only do that if you deconsolidate the market. So the point of the HHI-based proposal is to powerfully incentivize the deconsolidation or refragmentation of the provider market. It's not to simply reduce prices. It's to create competition as a mechanism for more innovation, more quality, and lower prices. So that's why that's important. And the other piece of it too is if you use employer prices as a benchmark, you don't really lower prices, right? Because employer prices relative to Medicare are already 3x Medicare, right? That's the problem, is that's already unaffordable. So you don't solve that problem with just using employer price as a benchmark. But what you do if you use is the HHI model is to say, okay, if you have a choice between 3x Medicare and Medicare or Medicare Advantage in our context, that's a powerful incentive to deconsolidate, right? Because if your prices have to go down by 2/3, then you're going to say, you know what, I'd rather keep my prices higher and have competition than to simply sit here and eat a 2/3 price cut. So it creates a powerful incentive for deconsolidation. That's really the point of this. It's not really about simply setting prices. In fact, the goal is the opposite. It's to restore a free competition among independent providers. And I should also mention that on the HHI point, in the legislation that was introduced originally in 2018, the idea in there is that the HHS secretary actually has the option of using things other than HHI. So obviously, or I shouldn't say obviously, but there is plenty of a reason to refine or think through other measures of market concentration without getting too wonky, depending on the context. And we leave a lot of flexibility in the legislation to address that and to create more room for newer and innovative and more specific approaches to measuring market concentration. So then, to get to Brady's question about balanced billing, you don't necessarily have to ban balanced billing. You can structure the way that the MA price ceiling works to account for that without banning balanced billing. That's the short answer.
We're unfortunately running out of time here, but I do have another question on here. I want to raise it to Erica and Suzanne. How can more employer-sponsored purchases use and apply provider and insurer price transparency data on the consumer's behalf? How can we shift the onus to the employers versus the consumer? Suzanne, and I want to leave time to get back to Lamore on the pharmaceutical question. I don't want you to get away until we get to the pharmaceutical. So Suzanne and Erica, any thoughts on that question?
Yeah, I mean, just quickly, Erica was right when she said that the evidence shows very few consumers actually look at price information and shop based on it. So I do think that the best place for it to be used is with the employer, or with those who advise employers, or with the health insurance companies or payers who have access to that information, to design new options for health insurance that are based on providers who deliver very high value, meaning the best combination of quality and cost. And that could be achieved just simply by lopping off the 15% most expensive providers. Americans love their choice, and employers often run scared that there'll be a lot of abrasion with their employees if they do something like that. But I think if they offer it as a choice alongside a broader plan, they will be happily surprised by how many people are interested in an option that is less expensive and where some of the homework has been done for them. And certainly among our membership, we've seen some very high selection rates of those types of plans, as well as retention over time. But with that, I'll turn it to Erica.
Sure. So I would agree with what Suzanne said. I mean, I think a promising way that employers could use this is really in network design and creating networks of more low price, high value providers. And we have seen employers do that in certain cases. I don't think every market supports employers being able to do that. There's not always sufficient provider choice in different markets, but there are certainly places where they could do that and could use it more. One thing we haven't talked about yet that I think is related to this and that could help with this is policy that would ban contracting provisions that are anti-competitive that providers use in their negotiations with insurers. So things like anti-steering provisions where providers will sometimes not allow the insurers to design plans that do steer the consumers to lower cost providers. And so I think banning those types of anti-competitive contracting practices could enable employers to do this type of smart network design even more.
Absolutely.
Thank you. Lamora, I think you have a rejoinder. I think it's to Ovik.
I do have, I'll try to keep it brief to Ovik, because really we are aligned in wanting to encourage competition. I hadn't been so optimistic as to imagine disintegration, although there will be divorces if the benefits from market power are reduced. But a remark about why limiting this application of these price caps to areas that are calculated to have this threshold HHI is anyone who's litigated a hospital merger knows that the market definition is hotly debated and it varies for every single hospital. So actually trying to measure the competitiveness of the market that hospital faces is super difficult. And it's just that's a crude approach. That's really what it is. And I worry we would miss a lot of the action, because even in markets that say like Boston might on the face of it look very competitive, we have a pretty big, lot of evidence that we've got a lot of market power on the part of a big dominant system here. Second comment on that, Ovik, was you rightly pointed out that with private prices so high, why would you benchmark on private prices and say, let's cap the maximum price at something related to private? And I would say that our proposal looks at the distribution of private prices and actually proposes taking the 20th percentile and multiplying that by 5. That's how, and still is more aggressive than like a 300% Medicare cap, which just goes to show you how extraordinarily high some prices are. But the 20th percentile, where you're kind of barely hanging on, but you're hanging on, multiply that. So we try to address that, and we also cap that the 75th percentile nationally of that. So that's a detail, but I thought a relevant one to say that it wasn't as linked to the high private prices as might have been thought.
And
Bill.
Lamar, just given a few minutes that we have here, staff have really educated me on this. I had never really given it that much thought.
Yeah.
The drug copay coupons.
Yes.
Tell me about.
All right. Any magazine you open up in your doctor's office, you will readily see there's a drug, typically a very expensive drug, and there's a card that says, if you take this card to your pharmacy, then you will have a 0 copay, right? That's a typical copay card. What does that do? Well, research shows that it makes you likelier to consume the brand when there's a brand and generic available. Okay. Also shows that it increases the sales of the drugs that have these coupons. On the counter side, so it increases access. Yes, that's the pharmaceutical manufacturer's objective. On the purchaser side, it means 2 things. First of all, that they can't use this tiering structure in their cost sharing to encourage you to buy a generic or to encourage you to buy lower cost therapy because they've negotiated a better price for that particular brand versus another. So it disables the mechanisms that are in place to try to free market wise negotiate prices down. So these coupons are softening price competition.
Right. Very good. Listen, we were almost out of time here, and I want to thank you, Erica, Ovik, Suzanne, Limar, for your discussion. It's really great. Personally, I also want to thank the BPC staff that helped prepare an awful lot of good questions. Marilyn Serapina, Sabat Bakanar, Kendall Strong, and Brady Newell. But I want to also thank all of you who tuned in on this. Real quick, 30 seconds maybe. Any final comments? Go around the horn here. Suzanne?
It's all about the prices these days. So we got to figure something out, or employer-sponsored healthcare is going to be a thing of the past.
Great. Ovik?
I've spent a lot of time today, as many of us have, picking on the hospitals, but I want to emphasize that this is a problem with physician care, particularly specialty care, and it's also a problem with prescription drugs, as we've touched on a little bit. So maybe we need 2 more hours to talk about those 2 topics.
Yes. Erica, any final thoughts?
Sure. I mean, it's been really encouraging to have a whole discussion around prices. I do think it really is the cost problem in the employer market. And so it's great that there's more talk about it. And I think the discussion today has really highlighted the need for people to think comprehensively about solutions. There were a lot of different types of policies that we talked about today, and that went far beyond kind of transparency. And so would just say, I think a comprehensive solution here is really needed.
Great. Thank you. And Lamar?
Yes, vehement agreement with everyone. I think it's going to take both employers and some top-down regulation to make a difference. We need employers to demonstrate price sensitivity by at least offering more options to their employees, selective network plans, and including things like these copay accumulators, maybe even copay maximizers, things that make that try to offset some of the incentives out there for pharmaceutical companies to drive up our spending. And on the government side, yeah, I think we're ripe for some price caps.
Okay. I think I want to again thank all of you. Really insightful comments, and prices is the issue that we're focusing on here. I think it's also clear that making modifications to the way employer-sponsored insurance operates is a challenging issue, and particularly in a bipartisan way. But I also think I'm a little bit encouraged here with the discussion that it's still both possible and, of course, I think it's necessary for rising prices going forward. So your input today and the work that we've been doing will inform our final product sometime, we hope, later this summer. Again, not to move away from employer-sponsored, but to strengthen it for the millions of Americans that depend on health insurance. So thank you all for tuning in and share with us your thoughts. And if you have questions, please contact BPC going forward. So good day. I appreciate all your time this morning. Thank you.
Thank you.
Thank you.
Thanks, Bill.